Wow. And welcome everyone to this week's Maternity and Midwifery Hour from 7 to 8. This is number 12 of Series 3. My name's Sue MacDonald. I'm the chair of this lovely hour. I'm also the curator for the hour and for the festivals as well. It's my pleasure to be with you this evening. And tonight we're going to do a little bit of reflection on the year that's just gone, as many people are doing this week for obvious reasons. And then we're going to move into one of the themes that has been a kind of constant theme in this year, which is about unconscious bias. And I'm delighted, and absolutely delighted, to introduce Lola Ornato. Have I pronounced that correctly, Lola?
Yes, I mean, I would say Lola. I always tell people my name is Lola, but actually, I was thinking today, why don't I actually just pronounce it properly and see if people can have a go? So,
Okay.
Ornato is completely correct, but the correct pronunciation of my name is actually Lola.
Lola.
Yeah.
Okay, Lola. Okay, I'll try and remember that. Thank you. Thank you for that, Lola. Okay. So we go, and we're going to include as part of Lola's session a few little revisits to sessions we've had before. So that's going to be really interesting and helpful, I think, for people who might have missed some of the discussion previously. And of course, because Lola's here, I'm going to ask her for her moment of the week, as we always ask all our guests for.
Well, I would say my moment of the week was fairly boring, but actually very satisfying for me. And it was the fact that I was able to have an hour's nap this afternoon while the children are at school. So I found it very enjoyable and I feel very rested now.
Wow. And that's a power nap,
Yeah.
audience. That's a power nap. That's a very good moment of the week. I can see you're refreshed and rejuvenated with that. So that's fantastic. Now, I'm going to do it slightly differently. I usually talk to the audience, but this time I'm going to just share my screen, and hopefully this will work out all right. Okay. Da, 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 da. That's it. Oh, it does work. How wonderful. I usually leave my speakers to be doing this. So I'm just doing a little bit of reflection 1 year on the Maternity and Midwifery Hour. And that's just to show how super we are in terms of having gold medals awarded to our YouTube channel. If those of you, when I'm talking, you'll probably hear about some sessions and you might think, oh, I need to go and find out about that. Have a look at the Matflix channel and you might find, well, you will find lots and lots of information there, lots and lots of resources for you to be able to use. Now, I'm just reminding everybody that this time last year, we were all very excited. It was the year of the nurse, the midwife. We had lots of celebrations planned. It was very fantastic. And then what happened? This old business, the Covid-19 arrived and things were very different. And actually, we had to know that we were going to have a lockdown, which happened this time yesterday, last year. The lockdown happened and we knew we wouldn't be able to present any live face-to-face events. And we really were very keen to provide something for midwives, for student midwives, for doulas, for anyone really working in maternity services, to keep them up to date with lots of information and support in in manageable sections, rather than a whole day as a conference. At that point, we planned an hour. So there we are. There's the stork bringing the Maternity and Midwifery Hour. So that was our whole purpose behind this. And because Neil Stewart's associates who run these events with Matflix have got a very long experience of online and recorded events, we knew it would work and it would work well for our audience. So that was that, and I'm sure that those of you who watch it will know about this anyway. But these are just some of our speakers. We've had some fantastic speakers over the year, and we've tried to include things that really will help midwives, will help student midwives to cope with COVID and also practicing at this time. And we know that mostly midwives have stayed in maternity services, but they still have been pressured by the events of COVID because people have been off sick, people have been very stressed, they've had to cope with the PPE, they've had to cope with the new language that's come from things like personal protective equipment and masks and everything. So we've included things like student perspectives, new regulations, we've looked at long COVID, we've looked at bereavement, we've looked at infant feeding, we've looked at COVID data and the evidence that's really generated hugely. We've looked at compassionate care, we've looked at sustainability and being eco-aware. Very importantly, we started with looking at well-being and looking after yourself, and we have had that as a theme throughout the year to make sure that people are looking after themselves, because I think one of the difficulties is if you're in the health service and you're also, you have a family, you have responsibilities, you're very much balancing everything and working very hard, and we know that midwives have been working very hard, and student midwives and healthcare support workers, everyone in the maternity services. So big thank you to you all just for the time being. We also have had MBRRACE, we've had Chai and Chat with the Assam midwives, we've had lots on the COVID vaccination and a lot on the maternity services and how they've coped with COVID and providing different levels of care. And, you know, moving on to technology, making sure that women and their babies are looked after, but safe, and have their services continued. And last week we're looking at continuity of care. So there's a lot here. And if you've missed any of these things, they're all recorded, so they're all accessible to you, so you can have a look at them. This is just a wee snapshot of the Maternity Midwifery Hour. And you can see we've done equality, we've done risk and parents' voices, we've looked at COVID, we've looked at MBRRACE, we've looked at self-care, mental health and the vaccine. So we've been very busy, and this is one snapshot and this is another snapshot, all these people. Now just think, some of you out there might be called upon to come and speak at the hour, and we'd love you to do so. So if you have an expertise or you want to share something, there are two ways of doing it. One is to contact Neil Stewart Associates or me, or you can tweet, which is what our speaker today did and attracted my attention on a subject that needs attention. So there we are. These are all our lovely speakers. I think I've included all of them. And I think what I've found from this last year, it's been a very hard year. And I know there's some people who haven't had very much to do, and there's been a lot of us who've been much busier. And it's been very difficult to balance a different way of life. But what has been really, really encouraging to me and nourishing to my heart as a midwife and as a nurse is how the public have really valued the NHS and health workers, and they've really come up trumps all the way through. And for me, it's really the strength and the value of that NHS family has really shone out. The teamwork and support has been fabulous. The kindness and compassion. I mean, when you hear people talking about what's happened, a member of their family is being cared for in intensive care, and the staff have gone over the limit to try and make sure that they're cared for and really have an opportunity to interact with their loved one. The kindness and compassion is fabulous. And I think in maternity services, I think the strength, the love and the commitment of the midwives and the maternity service family has also come over really well. And in most cases, women have kind of reported how well they've been looked after. Obviously, they've had difficulties because for a period of time, partners were excluded for obvious reasons. And now that's kind of been ameliorated. It's a lot better. But I think women have felt cared for in the most cases. And I think the other thing that's hit me is the innovation. I think we've achieved more this year than we've probably achieved in the last 10 years in terms of technology. Just look at the Zoom meetings and the Teams meetings now. We're not having to travel around to meetings. We're able to meet much more easily. And that includes being able to see women and be able to give them advice over the Zoom or the Microsoft elements. I still miss the face-to-face, and you'll see at the bottom of my picture, I've got a picture of one of our festivals, and I think that was one of our last face-to-face conferences. And I know that people miss, and midwives especially love to get together and to talk and to be together. And I think that's one of the things we miss. But I think the way we have Zoom meetings, for example, does help. That we've been trying to create ways of making sure we get that communication. I think the continuity and keeping everything going has been fantastic, but it also has been a time of huge learning and a huge challenge to us all. And I think we have to kind of acknowledge that some things have really brought into sharp focus. So what we've learned about looking after ourselves is we are strong, but we also need to recognize when someone needs support. Things like resting when you can. Now, Lola has illustrated brilliantly. She was tired, she had a rest, and that was fine, and that's good. And we need to look after ourselves like that. We need to be kind to ourselves and to our colleagues. We need to recognize when somebody needs just that little bit more support. I noticed on one of the news programs last night, this ICU team, they were looking after each other, and you could see how close they were together, and that was fantastic. And I'd like us at the end of this, if there is a complete end, that one of the things we'll have is that closeness and that teamwork would be fantastic. So it's okay not to be okay. Having a personal strategy for caring yourself, really important. I think we started our sessions with Jenny and Sheena talking about having a personal strategy for caring yourself, like working out as a team. This kind of idea of wobble rooms, budging with a colleague. I loved Jenny's idea of having a sanctuary box, of having this sort of emergency kit to look after yourselves. And also, of course, thinking about exercise and good nutrition and going a bit easy on the chocolate. I'll say that because I love my chocolate. And for what of the coming year? Well, we're aiming to have a series 4, so look out for that. And we obviously still are running the Maternity and Midwifery festivals totally online at the moment. We've had some stunning speakers in the past, and we're carrying on with that. We're also looking to find any new topics that you think would be useful to you in practice. And we're quite happy to have a few more clinically things. We will go towards there, because we really want to grow the resources at MATFLIX for you when you're doing work, for those of you who are students, and for those of you who are midwives who may be looking at revalidation. Loads of resources there, but we always want more, of course. And we just want to say a huge thank you to our NHS staff, to our intensive care units, high dependency units, obviously the maternity units, all the key staff, and that includes everybody from the cleaner to the porter to everybody who keeps the place going in the units. So here's some nice flowers, nice pretty flowers to keep us going. And I also need to thank the team who bring this to you. And that's Karen and Neil Stewart, who run the whole thing, with Catherine Stewart as our technical genius behind the scenes. Dr. Jenny Hall, who some of you will know, who chaired a couple of these days, these hours, and also looks after the MATFLIX, putting them together with the reflection and reflective tools and everything. And Paul Rushworth and Deborah Murray, who look after the real back room of getting the tweets through to us. It's a lot of work, and they're absolutely fabulous at what they do. So thank you to that team. And I want to thank you all for joining us every Wednesday. I hope you continue to do so. You see, I include all for maternity in the practicing midwife and MATFLIX because there's our support at this time as well. So thank you to all of you for joining us, and keep going. Not next Wednesday, though. We're having a little Easter break now. Okay, no, I've just stopped sharing. Okay, so I'm going to just, I don't have much in the way of news this week, funnily enough, because I think the news to me, it feels as though it's been very much focused on reflecting on the year gone, and maybe we'll need to start reflecting on the year to come. So that's our focus for today. Now, just moving on to now, I'm going to introduce with great pleasure. First of all, we're going to have a little video with the speakers who've spoken before, who you may have heard before, and then we're just going to play that video now, and then I shall introduce Lola to you. I'm trying really hard, Lola. Sorry. Go on to the video now.
So let's think about why they say that Black mums and their babies are dying. Some of you will have heard me talk about this before, so it will be a refresher. Others won't have heard this, and some will think, well, it's because of, and these will be the reasons that I list. So what we're told is that Black women are more likely to die because they are predisposed to particular conditions. Black women are more likely to die because their bodies somehow don't work as well. And that's known as eugenics, because the study of eugenics, which was started by a British scientist, says that white bodies are superior to Black bodies. Two things to consider. How can that hypothesis be true within maternity, that several extra layers of melanin means that you are at risk of death? Something else to consider, Black and brown people are the global majority. So if our bodies were as weak, then obviously we would be the global minority. So let's think some more about why we do nothing. When we discovered that women who smoked had lower birth weight babies, what we did was we educated the families, the healthcare professionals, the community, the world. When we discovered that laying babies on their back when they went to sleep reduced the incidence of sudden infant death by 75% in 1 year, we made sure that everybody knew about it. When we decided that Black women are predisposed to cardiac issues, hypertension, obesity, etc., and obesity, incidentally, is measured on the white Eurocentric model of what good weight looks like, we said that we needed to do more research. So I've just come away from the inquiry into maternal health inequalities. And we know that the research has been there for years, but perhaps the research isn't being utilised and used. So then we move to socioeconomics. Well, we know that statistically, Black and brown families are more likely to be at the lower to the bottom end of the socioeconomic scale. But studies also show us, and again, this study has come from the States because we're not quite ready to admit that racism works in the same way here in the UK, that a white woman with no education and no money does better than a Black woman with a university education and a middle class, upper class lifestyle and finances. And the last thing is the lack of education. We don't know what to eat. We don't know the classes to go to. But of course, why would we go to the classes when the vast majority of the imagery shows white babies? And when we talk about things, we talk about, do you notice a redness? Do you notice that? And all of the parameters go straight back to the default equaling normal, normal equaling white. Serena Williams completely debunks this. Serena Williams is a top-class athlete with a very healthy body. She's incredibly rich and really rather intelligent, speaks in many different languages. But she wasn't listened to when she was, the day after her daughter was born, knowing that she had a history of pulmonary embolism and explaining that she knew what she was talking about. She had to really push until somebody finally listened, gave her a CT scan and the heparin drip, because they found that she had 3 blood clots in her lungs. So she would have died that day. If someone as well known and, for want of a better phrase, as articulate. Someone like Serena who can advocate for themselves because they have the socio-economic power, etc., behind them isn't heard. Then what for those of us mere mortals who are simply just living our lives? So the response of the birth world, and possibly, probably, maybe some of you too, is defensiveness. Oh my goodness, how can you say these things? There's no way. I'm doing this work because I care about people. I can't possibly be racist because look at the world I'm working in. Is anyone in talking about these things, is anyone calling you specifically, you personally, racist? Or are they talking about the system and the structure? And you work within the system, but it doesn't mean that they're talking about you personally. So the question to ask is, why do I feel so defensive about this? I also ask that you stop and you think, that you ask questions and you examine your own bias. And I use the word bias to keep you all listening in, because actually, the hard truth is there is a lot of racism there. It's not enough to be non-racist, swimming in a pool of racism. You have to be anti-racist, actively working against racism. And I say that because when we treat the least well, everybody benefits.
We know that in higher education institutes, there was already, I like to call it an ethnicity, not a BAME attainment gap, because obviously there's a lot of issues with the word or the term BAME, resulting in people feeling there's a loss of identity, and that using that kind of term loses people's identity. So there was an attainment gap of 13% between people from particular ethnic groups and white British groups of about 13% for first class or upper second class degrees. There was already a high dropout rate for students from particular backgrounds. There was complaints about Eurocentric curriculums and lack of awareness of issues affecting students from different ethnic backgrounds in undertaking higher education. And when we look at academic staff, there was inequalities in pay and promotion for academic staff relating to their demographic, lack of diversity in academic staff, and unconscious bias was also an issue. And the term unconscious bias, it means different things to different people, but basically it's about stereotyping unconsciously. So if you meet someone who you've met before from a particular culture, country, with a particular accent, the attributes that you put to that person, you would apply it to the same person with the similar characteristics. So that's what the simplest way of saying unconscious bias. And then within higher education institutes, there was lack of senior leadership from ethnic minority groups. And this was important, an important fact to consider, because if you have a diverse student body, but when you look at their academic staff and they are not diverse, then what does that reflect to students who are studying on the course? How do you think they feel when they see, right, there's no one that looks like me teaching me this course? Do they really understand what I'm going through? And am I able to be transparent with those people about how I'm feeling? If you go to the NHS, similar issues, but in this case, likelihood of midwives from particular demographics to undergo disciplinary procedures locally, likelihood for these people to be referred to the NMC, cultures of bullying and harassment, organizational culture of discrimination and racism, again, unconscious bias, stereotyping unconsciously, lack of senior leadership from ethnic groups. Now, there's been lots and lots of issues around, we need to tackle this. Lots of organizations developed to tackle this. But we know that at the start of the COVID-19 pandemic, these were issues that we were dealing with already.
Okay, what else can you do? So during lockdown, I was opted out of clinical practice. This was around the time that George Floyd was murdered, and I'm Black. I'm quite visibly, unambiguously Black. I'm aware of racism. I know it exists. I know it exists in every single country in all different guises. But the murder of George Floyd, I couldn't watch the video. I couldn't watch him die. I couldn't watch him be murdered. It was awful. It was extremely harrowing. And I was numb for a good few days. But actually, it also acted as a catalyst for me to use my social media platform to advocate for cultural sensitivity in midwifery practice and midwifery education. So I have a background in pediatric nursing, and I'm familiar with the term Mongolian blue spot. But following Mr. Floyd's murder, I began to examine the language that we use in practice, the language that we are taught at university. I began to examine society as a whole, starting with what I knew, what I'm familiar with, which is looking after sick children and babies, and now looking after healthy and unwell women in pregnancy and following childbirth. So I began to look at the language that I've been taught. And I started with Mongolian blue spot, and I really started to ponder, where did this terminology come from? Because I know that this birthmark can present in children that are not of Asian heritage. So I looked into the origins of who coined the term. I very much suggest that you do the same. And I also began to wonder why, if anything, the term Mongolian blue spot is inaccurate because it presents in children of all types of ethnicities. It's not just exclusive to children of Mongolian heritage. So firstly, it's inaccurate. Secondly, it's racially insensitive. Please do look that up. And there are multiple alternatives. You can call it a blue-grey nevus, a slate-grey nevus, or congenital dermal melanocytosis. There are so many terms, alternatives to Mongolian blue spot, that we really don't have an excuse to keep using this racialized and outdated and inaccurate terminology. And after this social media post that I made on Instagram, I received quite a few DMs, so direct messages from not just student midwives or midwives, osteopaths, podiatrists, pediatric nurses, and a number of them wrote to the NHS website, which is where I found this image. It says blue-grey spots. This is what they have changed it to, but originally this was termed Mongolian blue spot. And I believe that if you look at the NHS website, I think for Wales, it still says Mongolian blue spot. Don't quote me on that, but please do have a look. You have power. As an individual, you have power. If you use social media in the right way and to be a positive influence, you can affect change. I made this post. A lot of people swarmed together to contact the NHS, the curators and the organisers of the NHS website, and it was changed. What else can we do? Just think about that. So I made this post in June. By July, it was changed.
Okay, well, that's a very clear little number of videos from Mars and from Sarah and from Alicia, really illustrating some of the issues we have to deal with. And this evening, we're going to focus on addressing unconscious bias. And this actually is a term that's become very much part of our language, and it can even feel a bit like a cop-out for some in some ways, and it's becoming a bit controversial. And so you can ask, what is it? Is it really unconscious, and how do we get more conscious? Because that's what we need to do, and we need to move to action rather than just words, I think. And I'm really delighted to reintroduce Lola Ornato, and she's a midwife at Whittington here in London, and it's a bit of a repeat visit for Lola, and we're very grateful for her to making the time and having a little nap, so she's really fresh and lively for this. She's been a midwife for many years, not too many, but she's focused on continuity of care, promoting normality and on active birth. And one of her passions is really to educate women and educate students to educate women so they can really make informed choices and be really informed with knowledge and skills. So I'm really pleased that you're with us, and thank you, Lola. The screen is yours now.
Thank you, Sue. So I'm just going to start sharing. See if I can find my presentation. Share sound. Okay. I think my screen has frozen for a minute. Okay, it's not. I'm trying to move my slides though, and they're not going anywhere. Let's go now. No, okay. Hang on. So, okay, it went a bit mad, I think, for a bit. There we go. Yes, it did that the last time. Yes, it also needed a nap. I've not been looking after my screen. That's very true. So thank you very much, Sue. Yes, so I just want to expand a little bit on what we watched from those three amazing women. And I'm going to just very quickly go through a little presentation that I have done with some students and also with my colleagues last Friday. And it's just exploring unconscious bias and what it actually means, and also using it as a way to reflect and improve outcomes of Black and brown women and birthing people. So I'll be asking a few questions in between the presentation. So if you could type the answers in the chat box, that would be really good. So I'll just go on to the next slide. So I like to give people a little bit about me before I do these presentations. So I studied at the University of Hertfordshire and I qualified in 2003. And my passion is for normalizing birth and advocacy, so advocacy for women. This picture here is of my great-grandmother, this picture has always been in our house, and my dad never really, I mean, he spoke about his grandma a lot because he was brought up by his grandmother. His mother died very young. But it wasn't until I started my midwifery training that he sent me a letter halfway through with this picture to tell me that actually she was a traditional birth attendant. So he said he just thought it was just amazing that I had, not unknowingly gone into the same profession that his grandma was in. And at the time she used to get paid in goats and chickens. There you go. So when I ran this session, it was a sort of group discussion, but if you want to, maybe just type a little bit about what you understand by unconscious bias and whether you can identify the different types of bias. So I'll give people like a minute or two to do that, or a few seconds actually to do that. If you could tell me anything you know about unconscious bias, and if you know if there are any different types of bias, basically. So. Okay. Right. So as you're typing, I will go on to the next slide, which does discuss it, and we'll see if we match up. So what is unconscious bias? So it's defined as the social stereotyping of certain groups of people that individuals form outside their own conscious awareness. So basically we're saying we're not aware that we form these biases. And the Oxford Dictionary definition is an unfair belief about a group of people that affects your behavior and decisions. So moving on to the types of bias that we might have. We've got color or culture bias. So that's kind of self-explanatory. So you look at someone's color, and because of the color of their skin, you have an already formed bias about how they might be. And also maybe an assumed culture as well. You think because they come from XYZ or because they look like XYZ, their culture is going to be like this. And then you make judgments based on that. Have gender bias. So again, self-explanatory. One of the major types of gender bias is inequality for women against men. So women doing the same job but getting paid a lot less than men do. Ageism, so again, discriminated against people because they're either too young or too old for a certain role. We have name bias, so you hear somebody's name and you automatically connect them with something either negative or positive. One of the examples of this that I thought was really quite clear was just after 9/11. I went to the States, and you get to the gate and they say they're doing random checks on people, and almost everybody they called had a name like Mohammed or something that sounded like it wasn't American, or sounded like it could be the name of somebody who might be a Muslim, and they would say at the beginning that they were not discriminating, which clearly wasn't true. And confirmation bias is when you have a preconceived idea about a certain person or certain culture, and then you meet them and they kind of tie in with what you think about that culture, and then it kind of confirms your bias, and you think, oh, I was right because I've read that this is what these kind of people do. And then maybe it could just be one characteristics out of the many that you've thought, but you will then use that to confirm your bias and almost justify treating that person unfairly. So what are the effects of unconscious bias on midwifery care? How do you think unconscious bias can affect the way we treat our women? So it can almost be a bit of a vicious cycle. So Black and brown women and birthing people are not treated with equity, leading to unacceptable levels of morbidity and mortality. They then become marginalized communities that become mistrusting of maternity services, and they might be reluctant to engage because their initial experience has been negative. We then label them as difficult and unwilling to engage, and the cycle of substandard care continues. So we put the blame on them. Oh, but they don't attend, they don't do this, and they don't do that. But we forget about the fact that it's our bias that has actually made their care substandard. So a very quick look at the racist roots of obstetrics and midwifery. This is a very popular image. I don't know if anybody knows what's going on here, but this is the image of Dr. Mariam Jane Sims. He sort of perfected his art by practicing on enslaved women, and he used them to try and perfect his craft on treating obstetric fistulas. Of the women that he worked on, they went through numerous operations. They nearly died. He had medical students coming in to witness what he was doing. And when he did try it on white women, not one white woman could withstand one of his operations. So if any of you can remember, we do actually have an instrument named after him. It's the Sims speculum. And a while ago, there were lots of people who were asking for the name of this speculum to be changed because of the legacy that he left behind. He also experimented on enslaved babies. He believed that neonatal tetanus was caused by a misalignment of the skull. So he tried to maneuver the skull with a very crude instrument. I think it was a shoemaker's. I think it's called an owl. I can't remember, but he had a 100% mortality rate with this procedure, which meant that all the babies he experimented on died. Not one of them survived this. Now I bring this up because I was doing a little bit of research around Dr. Sims, and I was looking at recent articles that have spoken about his work. And to my dismay, I will actually say I wasn't particularly shocked, but I read an article as recent as 2018 where the writer was claiming that people who were protesting about this man were being hysterical because, ironically, the highest number of sufferers of obstetric fistulas were African women. And it was almost as if he was trying to justify what he had done. So we're not denying that he didn't sort of create an operation that solved this problem. but we have to acknowledge the way in which he went about it. And another article that I read that I thought was, I mean, sometimes I look at these articles and I wonder, how do they actually get published? But another one of them speaks about his diary. So he kept journals. Obviously, he wrote about the women that he operated on. And he almost implies that the women gave consent. For me personally, I think if you are talking about enslaved and consent in the same sentence, then there's something wrong with your brain. And I think what worries me the most is that there are people who are talking about this, you know, and we're not talking about it in the 1950s. We're talking about as recently as 2018, and actually the last article I read was 2020, who feel that what he did was not a big deal. And when you think that some of these people are healthcare professionals who are looking after Black and brown women, what kind of bias have they got in their minds when they go in to look after these women? I think for me personally, that is an extremely scary thought. So what do we think about how history has shaped our practice today? So I'm going to sort of whiz through the answers, but if you want to add anything to it, you can do. And I'm sure Sue will pick them up when we get to the discussion and questions bit. So examples of unconscious bias in practice. So these examples are things that have happened sometimes to me. I was speaking to a friend of mine who is a doctor, and so some of the examples are things that he has also witnessed in practice. So recognition of skin conditions in darker skin tones. So Alicia picked up on that as well when she was talking about the blue-grey spots that were known as Mongolian blue spots. And I can give you a personal example on this. Years ago, when my daughter was really young, we went to Italy, and she had what to me was obviously chickenpox. The night that we landed, she felt a bit warm, and then the next morning she had spots on her. So we took her to the pharmacy, and they were very lovely. But the first pharmacist said, I don't think this is chickenpox, this is insect bites. So I was like, okay. So she didn't want to give us the lotion because she thought you wouldn't need this for insect bites. So I thought, fair enough, but I don't think these are insect bites. We went to the second chemist, and she said the same thing, but she wasn't sure. So she decided, well, I'll give you the lotion, but I'm not really sure that it's chickenpox, but keep an eye on her. So I didn't really think anything of it. I thought it was a bit strange that I had thought this is definitely chickenpox, and they didn't seem to be agreeing with me. When we got home, my sister-in-law said to me, they probably haven't seen it on brown skin. And to be honest with you, I've only thought about that situation probably in the last few months, that, wow, you know, there's this chickenpox, which usually is a fairly, you know, straightforward illness in children. But what if it had been something more serious? And because of their time, in the time they took to diagnose it, it could have gone so horribly wrong. So to think that even chickenpox, which you think is quite a common ailment in children, that you would have some people who would not be able to recognize that in a child with darker skin tone. Assuming that Black and brown patients do not require analgesia. So a lot of the blogs and stories that I read about Black and brown women, especially and birthing people, talking about their experience is being denied analgesia. And you might not think this is a big deal, but I have read articles where there have been medical students that have been spoken to who truly believe that Black and brown women or Black and brown patients have thicker skin and therefore do not feel pain as much, and they will withhold analgesia based on this. My doctor friend also said when he was in hospital, he asked for pain relief following having his tonsils removed. And he was actually told he couldn't have it because they didn't want him to become addicted. And he was told that to his face. It then turned out that he actually had PRN medication on his drug chart. So again, coming from health professionals, I think that's actually quite sad to hear, but also kind of scary that we would deliberately withhold analgesia from one group of people based on nothing really. So negative language is used to describe a condition for Black patients while using more positive language for white patients. So again, you hear the term personality disorder with a lot more Black patients than you do with white patients, and you hear the term bipolar used more with white patients. Labeling certain patients as having poor English skills rather than acknowledging their accents. So again, not taking the time to understand somebody just because they don't speak like you, when actually they have very good communication skills, but you've already looked at them and judged them the minute they come through the door and thought actually they have poor English. Using family members as translators, having decided that the patient does not need an official translator. So I've witnessed this in practice before. Assumption of recreational drug use with certain ethnicities, and assumption of FGM practice within certain communities. So again, one of my colleagues brought up the fact that actually FGM is not just practiced within Black and brown communities. There are actually white women who suffer this as well, but sometimes we make an assumption that it's only with a certain community or certain group of people, normally Black or brown, who come from certain areas of the world that would have FGM. So the implications for this is delay in diagnosis can lead to rapid deterioration. If you don't know what's wrong with someone based on the fact that you have not had the education about different skin tones, and that could lead to a delay in actually figuring out what's wrong, and they could get sicker. Withholding analgesia can cause both physical and emotional pain. A lack of appropriate interpreter can lead to not understanding vital information and vice versa. Negative descriptions of patients or conditions or assumed behavior can lead to unfair treatment from staff. What can we do about this? So the first thing is that we need to acknowledge there's a problem. And at the moment, so many of us are not acknowledging that there's a problem. So I'm going to ask another question, which you can type into the chat box. Since the MBRRACE report came out, and since George Floyd died, and since there has been a lot more discussion around inequalities in maternal health, I would like you to share with us if anything has actually changed where you work. So are you receiving any unconscious bias training? Are you receiving cultural sensitivity training? Are you yourself doing anything about it if nothing is being done? If you're a student, has there been a change in your curriculum or the things that you're learning about? So we are all human and we have biases. So I have a bias, I have several biases, and I'm aware that I have these biases. So it's not just white people who have biases, Black and brown people have biases too. We need to be able to say that we have that. And if we can't accept that, if we keep going on with the mantra that we treat everybody with equality and you don't see color, I mean, please try to stop saying you don't see color. If you don't see color, there's an issue there. You should be seeing color, and you should be acknowledging that actually, because somebody is a different color, they might be treated differently. And that is why we need to acknowledge our bias. And the other thing as well is, I think Sue kind of touched on that briefly, is our bias is unconscious. Some of them might be, but it's almost a lazy way of saying, oh, well, you know, we didn't know about it. It's unconscious. Oh, well, a lot of it actually is not unconscious. It is something that you know you are doing, but you do not want to change that behavior. Awareness, so recognizing the bias when we look after patients and making a conscious effort to put it aside. So no matter what you think of that culture or color, put it aside and start afresh and be led by that person. Education, decolonizing the curriculum. So if we are not teaching our medical students or our student midwives or student nurses what to look out for, how are they supposed to learn on the job when all of us who have gone through that education learnt the same whitewashed curriculum? So we need to start changing the way we educate people. Educate yourselves as well. So I was listening to the little bit of Alicia's talk, and I heard her say educate yourself. So I have deliberately not shared with you the articles that I read, because I think part of having an interest in actually pushing for change is to go and educate yourselves. There is so much out there when you go on social media, when you go, there's so many articles that you can access online, and it shouldn't be up to us always telling you what you need to do to access the information. It is out there for you to look at, and part of you being willing to change is going to seek out that information for yourself. So the other thing I wanted to say is, if you think nothing has changed at your unit, perhaps you'd like to tell us why you think that's a problem. Is it because you yourself are being quiet? So again, if you listen to what Mars said, it's not enough to be, it's not enough not to be racist. you have to be, you know, you have to do more than just saying, well, I'm not a racist. You have to push for change. You have to support us. You have to be our allies if you want things to change. Otherwise, they will stay exactly the same as they are. So a quick quiz. I'm just looking at the time because I'm hoping that we can take a few questions after this. One of the things that I think about really examining your bias is that it shouldn't just be applied to maternal health. It should be a way of life almost. And so I've got a little quiz here that I like to play, and it's about being aware of other people of color who are black or brown, who you may or may not have heard of in the media or seen pictures of them, and just trying to test your knowledge of other cultures other than, you know, people who are white, and what these people stand for. So you can have a quick look at this, at these pictures, and see how many of them that you have spotted. So I'm going to tell you who's who. So first lady is Chimamanda Ngozi Adichie. She is a Nigerian author, and she's written loads of books. You might have heard of Half of a Yellow Sun, which is a book that talks about the Nigerian Civil War in the 60s. And actually for me, that was quite a good learning curve, because even as a Nigerian, I knew about this, but I didn't really know the ins and outs of it. So it's quite an interesting book to read. The second lady is Elizabeth Nneka. I think she has actually been on the Midwifery Hour at some of the conferences, but she is a nurse who helped to set up the Centre for Sickle Cell Anemia in North London. At the top, we've got Mary Seacole. So she was a nurse who wanted to go and help out with the Crimean War. She was denied this, so she set up a hotel herself and looked after sick people. And underneath this couple here are the Lovins. This is Richard and Mildred Lovin. Their marriage was termed illegal. So at the time, they were sentenced to a year in prison, and they had to leave the state of Virginia. They then decided that actually they were not going to take this lying down. And in 1967, they had their sentence overturned. And I'm not really sure why he's down there, but I think at the time I was looking for an image of Lenny Henry, and I don't know why he came up, but I quite like him as an actor. This is Donald Glover, and he's also a rapper, so some people might know him as Childish Gambino, so I just put him there because I like the picture. So again, it's just being aware of what do you know about actually influential Black and brown people, and why do you not know about this? Is it because what you are accessing, our education, our media, everything that we access is so whitewashed that we actually don't get to hear about the achievements of other people? So I have a very quick video. I think I can probably show this. It's literally, I'm not going to show the whole thing. I just want you to listen to the first couple of minutes of the conversation. Welcome and understand how bias can affect the way we speak to other people.
And do people read your books in Nigeria?
They do, shockingly. They do.
Est-ce qu'il y a des librairies? Are there bookshops in Nigeria?
Je vois. You know, I think it reflects very poorly on French people that you have to ask me that question. I really do. Because, I mean...
Okay, so I'm just going to stop that there because I just wanted you to hear the question. Oh, why am I not out of this now? Oh, trying to go onto my slides. I have to go to the end. Okay, so next slide. So finally, very quickly, what are you going to do about it? So be proactive and call it out. I mean, if you see inequalities, or you can see where people are not being treated equally, and that includes your colleagues, do not be silent about it. Take responsibility and enlighten yourselves. There are so many things available now: conferences, social media, reading resources. Use your powers for good, be an ally, and push for change in your place of work, cultural awareness training. And I'm just going to go to the last slide of my little doggy with the ears to say I'm all ears if anybody has any questions. And I will stop sharing now.
She muted me. Thank you, Lola. That was really fantastic. I don't know, people have put a lot of information, so thank you to everyone who's tippy tapping in. I hope you didn't miss a moment of Lola's session in your tapping in, but I know we've come through, and people who watch this know that usually things come through to me and I have to relay it, but it's a bit difficult when so much is coming through. So it seems as though a lot of people, and I think it's been fed through to the chat box, Lola, so you might want to just check it out. But I would say that the feedback is pretty well, people know what the bias is, and that the issue about pain and tolerance with people of black and brown, it seems to be a well-known thing here. I don't know, have you had a look, Lola?
Yes, so I'm just looking at some of the comments that come in through. So Gail Johnson says, can stereotypes play a part? But I think that's basically what we're talking about with the bias, is that if you're stereotyping someone automatically. And also I just wanted to put out a really important part that I went to school in Nigeria, and I say this all the time, that my education, even in Nigeria, was whitewashed. Like, we were always sort of led to believe that whatever white people did was better. And so, you know, we actually sometimes have a negative, something that we don't know that we're doing. We have a negative, we might sometimes have a negative impression of people from other countries without actually thinking, actually, we are talking about people who look and speak like us. So definitely stereotypes play a part if you have, and stereotypes can sometimes be really hard to get rid of, because again, if you're looking at confirmation bias, you have a stereotype that's been implanted in your head, and then you meet someone who ticks one of those boxes and you think, that's it, they are like that because that's what my mum told me, or that's what I was taught. So yeah, I'm putting them in that box. Yeah.
So
Rachel says
it's difficult to counter, isn't it?
It is difficult to counter, but I think recognizing there's a problem is the first step. Rachel says, I know if you give beta blockers to HCPs, they become less biased. I don't know what that means, HCPs. So
healthcare professionals. I think it's to do with the amygdala.
Right.
That's a physiological thing. And thank you for that, Rachel. We're both going to go and look that up immediately. Fantastic. I mean, it seemed to me that some of the comments that are coming through in your, you know, asking about what changes have people seen, it seems as though some people have seen some changes, like Diane. Hi, Diane. Says she's not aware of any great changes where I work. Since last year, I've read widely and listened to as many sessions as possible. I think I'm far more aware of how lucky I am as a white middle-class woman. I would agree with that. And I think Gail also says she has unconscious bias training, which is excellent. And I think somebody else had said, and they were having some training. And Natalie M. Now, this is a good point. I don't know if you got this one, Lola. Just realised today we had a lecture on wound management.
Oh yes, I saw that one.
All the signs of infection
that
were discussed were about white skin, and that's a really good point to
make. And I think even from a personal perspective, you know, the things that I didn't know about my own skin. So I was born here and went to Nigeria when I was 6, and I came back when I was 20, and I lived in the sun all the time. I did not know that I could tan because my skin was always under the sun and was always very dark. So on my first visit back to Nigeria since I came over here, all my cousins commented on how light my skin was. But I didn't, because I went back in the winter, but I didn't know I could tan. So I was really surprised when my first summer, how dark my skin got under the sun. But I didn't know that, you know, because nobody told me that. Nobody told me that we tan, you know, just like white people tan. So again, you know, you're having wound management, but you're only looking at white skin. How do you know exactly what to do when you see black skin or brown skin? It's just, you know, it's something that should be so basic, and we're not learning it. And it could be really dangerous. You know, I tell the chickenpox story because it was kind of funny at the time. And like I said, even when my sister-in-law made the comment, oh, they probably haven't seen it or on a black or brown child before, I didn't really think it was a big issue, but actually it kind of is, you know. I mean, it was so clearly chickenpox, and they couldn't diagnose chickenpox. What if it had been something really awful like meningitis? You know, if she'd had like a rash, would they have known what it was?
Yeah, I mean, and likewise for new babies who've got jaundice, being able to identify how you would tell how jaundiced a black or brown baby would be.
Yeah.
At that point, no, it's a good point.
Yeah.
Okay, you had lots of people did very well on the quiz.
They did
very well on the quiz. So well done for our audience for that. Mr. and Mrs. Love and Mary Seacole. Mary Seacole is probably one of the best.
Well, I thought most people would probably know Mary Seacole.
Yeah.
But I think Rupali, I think it's has said, we set up a multidisciplinary team to specifically address inequalities in maternity long-term project. And Karen says, yes, actioned Medi and Eddie Trust and maternity working parties. And Howard says, a lot of people are just saying they don't have any biases, still no noticeable changes. That's kind of not surprising, but sad. And Gail Johnson is saying, we have unconscious bias training, which is excellent. Training is essential, but some people choose to believe unconscious bias doesn't apply to them. And Ren says, no change in our curriculum, more needs to be done. So I've attended a few webinars and talks myself. And I think that's the thing, is that sometimes it's not about waiting for what's going to happen. It's about actually making the decision that you are going to educate yourself, and maybe through that you will bring about change.
And I think that's a good point that you kind of reflect on Alicia, and when you were saying that, and you've just said it, in actual fact, students can be very powerful. So those of you who are students who are listening, by equipping yourself even with a little bit of extra knowledge, and then asking in class, asking in the clinical area, well, how do we deal with this? And what, you know, why isn't there this system up and running? Why haven't we got a working group looking at this issue? And what is it about this unconscious bias? By asking, you'll get people to actually have to do something. Because I think we were having a discussion before the hour began, because one of the difficulties, I mean, it's like the maternal mortality, and therefore I suspect maternal morbidity in black and brown women is much higher than that in white. And it's not a new thing, it's been around for a while, and we're only just kind of addressing it and getting some action. And really it is time to just stop talking and well, we still need to talk, but we actually need some action as well.
Indeed. And I think that's one of the reasons why I talk about it so much, because, you know, I will say that I am just as guilty as having not done anything for years. And the MBRRACE report and the death of George Floyd was it kind of sort of spurred me on to talk about things that I felt I couldn't talk about, which I think is also the same for a few people. And I think everybody else needs to understand that actually the silence is killing women. It's as simple as that. And we need to do a lot better than what we're doing now.
We do. And we've got now we've got from Karima. Did you read Karima's?
And I don't think that's come through on my one.
She said, student midwife here. Hi, Karima. Thank you for saying something. After myself and one other student arranged a meeting with a lecturer about our dismay at our pretty whitewashed curriculum, we were informed our curriculum will be changing next year to be more culturally sensitive / inclusive. A little too late, I feel. There's not enough urgency about it. That's a good point, Karima.
Yeah.
But maybe,
I would agree with that.
I mean, the opportunity students also might have is if you're given some maybe work like doing your projects or your dissertations or seminar work, you know, you can take this on board and start introducing yourselves.
And I would also like to just say that so last year, University of Staffordshire actually organised, the students organised a conference, and that was from a few students being fed up of what had happened. And yeah, I spoke, Mars was there as well, and so was Beanish. But that was something that they had decided they were going to do because they were tired of the whitewash curriculum. So, you know, you do have that power to do something. You do have that power to change things.
Yeah, absolutely. And I guess that, I mean, I guess one of the uncomfortable things, if you're white, you can feel very uncomfortable about it all. And you can think, I'm not racist. It can't be me. I'm not biased. But of course, I think, and you put it beautifully, Lola, by saying that we all have biases, because we do. And it's the important thing is knowing about it and actually dealing with it, so that you're not going to disadvantage any woman that you're caring for. And actually, once you kind of identify it, you're getting to know people in a real true sense.
Yeah.
Which makes life a lot more interesting, actually.
Yeah. And I think one of the other things that I've learned from some of the seminars that I've attended is, you know, what you need to take on board is it's not about you. You know, it's not, you know, when people start telling you about figures and everything, it's not about you. It shouldn't be about you. It's about the women, and we are all part of that system. Black, white, brown, you know, healthcare professionals, we're all part of the system. So it's not about one person, and it's not enough to say, well, I'm not racist. Well, it doesn't matter if you're not racist, the women are still dying. So it's about changing the whole system, which you are a part of. So whether or not you are not personally racist, you still need to work on changing the system.
Absolutely so. Now, just to, and I didn't mention this earlier, but we do have a list of resources that's available. There's also some very good, I mean, there's some very good things on YouTube on unconscious bias and white privilege. And I would recommend that people who don't feel as though they don't really understand what white privilege means, maybe have a look at that. It's quite helpful. I think we are coming to an end, Lola.
Yes. I was just going to say, your pronunciation of my name has just got better and better.
Oh, I might get it right now. It's because simply for me, it's the spelling, because I think English, and if you're English, you're very stuck on pronunciation, and you work it out and you think one L-O-L-A, that must be Lola. Well, if it was L-O-L-L-A, I wouldn't have an issue. I guess Lola.
Well, I have to say, it is definitely a lot more difficult with an English accent, which is why when I'm speaking, you know, I just say it's Lola, you know. But I think, you know, I should probably start to pronounce, because my friends always say, why don't you just teach us how to pronounce your name properly? And again, my bias is like, because you're never going to learn how to pronounce it properly. But maybe I need to change that bias and actually start pronouncing my name properly. So, but no, well done on the name pronunciation. And I know we've got to go, but I just wanted to very quickly say the video, I got a bit flustered trying to get out of it because it froze. But I just wanted to say again, it's an example of bias. That interview was in 2018, and you have a woman asking if there are bookshops in Nigeria. And I think, well, even let's just say you are ignorant enough not to know. You're a journalist and you're interviewing someone who is a well-known writer. Do your research. So sometimes I'm left with the fact that she was just deliberately trying to be provocative, and that's not okay. But those are the kind of things that, and that's why I think it's almost like it needs to be a way of life. It can't just be about, you know, it has to be in every aspect of your life where you are constantly checking your bias and making sure that you treat everybody the way they deserve to be treated. And
the way you want to be treated yourself, I guess.
Absolutely.
That's the key thing. Well, thank you very, very much, Lola. That's been really good. We're going to have Lola back at some point, because she's such an energetic and thought-provoking person to talk to us. So thank you so much. And I think it's an uncomfortable issue, but we need to address it and we need to sort ourselves out. And I was sort of saying to Lola, one of the things for me is that once you start questioning this whole thing about structural racism and about unconscious bias, you actually have to acknowledge that most of our education, and I'm not just talking midwifery, is based on kind of shifting sands, because we don't know all of it. We only know one bit of it.
Yeah.
And I'm looking forward to learning a bit more about the rest of it. I hope my brain's big enough.
Sue, there is one little comment. I don't know if you can see it, but I think you've been asked to end on the comment. So if you can't see it, I can read it out. It's Samantha. I don't know if that's word or wood.
Wood.
Yeah, wood.
Yes, I've got it. Okay, Samantha says, I'm due to start uni in September. I feel after this I'm a lot more stronger. I've experienced unconscious bias all my life. I hope to help make changes just like you. Samantha, you are a joy. Thank you so much for that comment. That's a perfect way to end on. Thank you. And I would like to say thank you to everyone for coming and participating. I have to say this has been a very lively, and people have been making lots and lots of comments, and you've all got the questions right. The answers right.
Well done, everybody.
So well done. So next week we don't have an hour session, so you can have a nice Easter break with your sticky buns and not too much chocolate and too much eating. And we'll look forward to seeing you soon for series 4. Yes. And take care and stay safe. And thank you again, Lola. You're a joy.
You're welcome. Thank you for having me.
The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.matflix.co.uk.